Terrific, thank you. So we have about 10 minutes before lunch to take some questions for our three speakers. And maybe I'll start. I have a number of them, but I'll ask Catherine. You emphasized the importance of developing the use case. And I was just curious about how much time it takes to develop a use case. In your experience, how much time do you have to spend to get a really good use case developed?
Well, I can kind of go backwards. In a lot of our MVP type of projects, it's ranged from 9 to 12 weeks just to get to a product, our final application. And usually the first 3 weeks or a month is spent going around the room, having a design session, meeting with our statisticians, the subject matter expert, and especially the consumer, the actual policymaker who is interested in what they want to see out of the analytic, and drawing out a variety of wireframes on a whiteboard. And that can last anywhere between, in my personal experience, 1 week to 4 weeks. One example is something not related to health on a Navy project. It took us a while to tease down exactly what they wanted to do with their data. And speaking to a limited environment of technology, they had a war game. And so in their war game, multiple people were writing in moves like missile fires to platform, platform fires to platform. And what they were doing at the time was just literally typing in a huge Excel spreadsheet. And they came to me and said, I want some natural language processing. And so that sparked a conversation, well, you need Python, you need X, Y, and Z. But what they really wanted to do after a couple of weeks of discussion is they just wanted to automate this process. And so granted, they're just now got Firefox. They don't have access to all these publicly available tools. They have Excel. And so if you understand kind of the ethos of what they wanted to do with NLP, we essentially created an NLP pipeline for them that does the same kind of exercises that you would do in Python, but now instead of in Python, which they don't have access to, we did it in Visual Basics in Excel. And so it took a couple of weeks to get to that point, but that helps us kind of get to the idea of just focus on your use case and make the technology secondary.
Great, thank you. Other questions for the panelists? Rima.
Yeah, no, thanks. This was a great panel, great presentations, and the challenges mentioned on data sharing and data storage echo with us as we move to do more whole genome sequencing, especially generating huge amount of data. And so it's very, very challenging. I have a question for Dr. Lesho. We are also moving to replace the traditional typing like PFGE by whole genome sequencing, and I've started doing that for foodborne disease outbreak detection. Listeria is at the forefront of it, and it's very exciting, really saves time and saves, you're able to detect clusters earlier and smaller outbreaks, etc. We're working with FDA and NIH on that. One challenge that we're seeing, though, is, and I wonder whether you have experienced it in military hospitals, is that people are not doing cultures. So you have molecular detection of foodborne outbreaks. So you don't have isolates making their way so that you can type them, whether by PFGE or by whole genome sequencing. And until we get to a point where we do metagenomics or we can get the samples and sequence directly, it's huge. For Salmonella and others, the numbers are going down, and it's not because it's going down, it's because the isolates are not making the, are not there to make their way anywhere.
Exactly, and that is a very big problem for pathogens such as Staph aureus, which is all molecularly detected with the Cepheid, and C. diff. We also do C. diff, and sometimes what we have to do is we have to go back to the shoe leather and actually station a laboratory tech at the high volume centers, so that when those pings that go along, so they say, okay, that, the Cepheid pinged or alerted, go try to track down that culture and get us. Another problem we have is what I didn't have time to mention is that these multi-drug resistant bacteria, one of the most common platforms is a shorter read platform, which is good except for these. When you're trying to look at, because in the regions, the read length is such that you're missing insertion sequences, certain plasmids, and you can't really definitively determine the transmission pattern or the origination source without ultra-long read sequencing. Getting at the ultra-long read sequencing is another challenge because currently they're huge. One of the platforms weighs over a ton. Most organizations, the elevators can't handle it, requires ultra-pure nitrogen, requires its own dedicated power source, and it comes with a blade server. And by the time we logistically were able to incorporate that in our workflow, guess what? Obsolete. The manufacturer comes out with a smaller, cheaper, and that happens to us consistently.
Great. So we have 4 questions and 3 minutes until lunchtime. So I'm going to ask the 4 questioners to ask their questions briefly, and then we'll go through the answers all at once. So first Eduardo, and then Maria, Jeff, and okay. So we'll take those 3 questions, and then we'll have to wrap it up.
And thank you. Only short question is related to this resisting. You collected usually human use, and today we are very impressed about the One Health, because you know the veterinary use is very important in antibiotics, and we have several models about how is coming resistant from the animal to the humans, and Salmonella and the Shigella and other bacteria like Campylobacter have very clear history. And it's very easy to have the information about how much consume you have from veterinary use, because you know what is the amount of the sales from these products. Can you introduce this kind of item in your evaluation to have resistance in different bacteria, why you are not including the veterinary use?
Great. Let's take the next question, Maria.
I just really have a comment, and I don't want us to lose sight of it. So when I hear all these presentations on digital disease detection, I think we're going to have to make sure that we think about reuse of data. And I think as people are building maps and doing predictive tools, whether it's dengue or whether it's AMR, I think we're going to have to really carefully think about data sharing, data access, and then descriptions of the experiments and the metadata, so we can reuse data when appropriate and making sure that, you know, we do all the right de-identifying. But I think we need to think about this word of reuse.
Thanks. This is a question for Michael Edelstein. You mentioned that big data allows us to identify outbreaks more promptly, but the example you gave was of Ebola, which seemed to have been recognized more promptly retrospectively. So I was curious about whether there are other examples, or you're thinking that this is a potential to recognize outbreaks more promptly.
Great. You want to take a shot at those 3 questions? Who wants to take the first one? Go ahead.
I can address the last question and the comment, but it will be quick. Yeah, I mean, one of the criticisms of digital disease detection is that it's very good at detecting past outbreaks. There are examples, though, of prospective use and embedded use of digital disease detection. One of the use I can think of is one example where I was involved, which is a tool that the Public Health Agency of Sweden uses to detect the onset of the norovirus season ahead of hospital outbreaks, and it's been used for. So we validated the tool on 8 years of retrospective data, and now it is used prospectively and has been for the last 2 years, and consistently detects community circulation ahead of hospital. I think you're right. I think. And again, I think this is what the message I was trying to convey. I think we spent a lot of time validating this type of tool. I think we need to make the leap to start using it in practice, see how it works. I think the early results are encouraging, but it is still a maturing and nascent field. On data reuse, I'm not going to say much, but except that I totally agree with you. There was a very nice quote that I got when we were doing background research on our data sharing project, which was that, you know, when you're collecting research data in London or in New York, you don't know what someone in Toronto or Lagos might do with it. So absolutely right.
And I echo your sentiments on data reuse and data sharing, and to that end, the eventual goal of this DoD database is to be web-enabled, so that end users, as long as they have internet access, with the right security clearance and their CAC card, and they can get in the database, look at the inventory, and do queries and reports. And that's, we try to, Dr. Gutsu, to incorporate, it's a plug-and-play kind of thing. Drug usage in animals is a little harder to get, and it's also hard in humans from the data mining strategy, but you can substitute any pathogen, use that tool for any pathogen or any drug to study the relationship. But again, there's no substitute for the shoe leather epidemiology, because when you mine the electronic healthcare records for data for antibiotic use, it's very challenging to get the best measure, and that's what all the reviewers want. They want defined daily doses, or they want days of therapy. And it sounds simple, but when patients are frequently transferred from ward to ward or operating room to operating room, electronically, oftentimes it doesn't mirror what's happening with the dose of the antibiotic.
So with that, let me ask Lonnie, are you going to come back up and say a few words? But first,
So I won't even need to
join
go
me in
back up.
thanking
I'll
the
do it
panel.
from here. Let's thank our panelists first of all.